This PowerPoint is the effects of secondary trauma on social workers and direct social work practice, being presented by Jakara Lee, Jordan Schlotzauer, and Nicole Twitchell. Secondary traumatic stress has been defined as the natural consequent behaviors and emotions resulting from knowledge about a traumatizing event experienced by a significant other. As social workers, trying to help, advocate for, and assist clients can be overwhelming to the point in which self-care is not being implemented. Social workers are constantly working with individuals to help repair their lives, not knowing that listening to their clients' stories, problems, experiences, and issues could vicariously cause secondary traumatic stress in the professional. Social workers are working with clients that have experienced trauma, and the risk of secondary traumatic stress is high. This could possibly be a significant problem in the field of social work, but it can also be prevented if social workers are educated on secondary traumatic stress and learn ways to help cope with the struggles of the clients outside of work. The purpose of this study is to demonstrate that social workers working directly with clients who have experienced extreme trauma will experience secondary traumatic stress at some point in their social work career and may be at risk of long-term side effects such as burnout and PTSD.
For a summary of the LIT review, secondary traumatic stress is an occupational hazard of providing direct services to traumatized populations. The studies conducted by health professionals, sexual assault counselors, and trauma therapists have provided empirical evidence that individuals who provide services to traumatized populations are at risk of experiencing symptoms of traumatic stress. Up until recently, literature on STS was either conceptual or anecdotal, never addressing what STS symptoms actually look like. However, an increasing number of empirical studies that emphasize the direct impact traumatized patients have on social workers are being conducted and published. The most frequently reported symptoms of STS were intrusive thoughts and psychological distress in response to reminders of work with traumatized clients. Other symptoms included physiological reactions in response to reminders of work with traumatized clients and intrusion symptoms such as disturbing dreams and a sense of reliving the traumas reported by clients. If STS is not managed and treated, social workers are at risk to be diagnosed with PTSD. PTSD is precipitated by an individual's direct or indirect exposure to a traumatic event. The diagnostic criteria includes a person's response involving fear, helplessness, or horror. There are many forms in which information about secondary traumatic stress in the workplace can be gathered. A paper survey was passed out to 5 different individuals at each group member's practicum site for this. The survey that was passed out was pre-existing and was called the Secondary Traumatic Stress Scale, created by Bride, Robinson, Yegedis, and Figley in 1999. The purpose behind the development of the secondary traumatic stress scale was to conceptualize the characteristic symptoms of post-traumatic stress associated features. The secondary traumatic stress scale was based on the DSM-5 criteria. It's criteria B, intrusion, criteria C, avoidance, and D, arousal. The secondary traumatic stress scale is compiled of 17 statements that were made by persons who have been impacted by their work with traumatized clients. The people that were taking this survey were instructed to read each of the statements listed out in the survey and then indicate how frequently the statement holds to be true for them over the past 7 days. This scale is from 1 to 5, where 1 is never, 2 rarely, 3 occasionally, 4 often, and 5 very often. The specific findings from the survey will be explained later in this presentation. It was explained to the individuals who participated in this survey that their answers were confidential and would not be used outside of this literature review. and names were not collected from the individuals while distributing and collecting data from this survey.
The research sampling method that was used in this study is convenience sampling due to using the individuals at our work or practicum site. With the use of this sampling method, we were able to obtain results that could represent the population. The survey was handed out to 18 participants that have been and are currently working in direct social work practice with adults or youth for at least 2 years. These positions include case managers, supervisors, and directors that completed the survey. Due to the convenience, employees were just asked to complete the survey and hand it back to the researcher. Informed consent was given to all participants at that time. All participants were given information about what the survey was being used for and how long it would take to complete the survey, which was about 5 to 10 minutes. The advantages of using convenience sampling is that it's very cost effective and you can choose and achieve the sample size that's needed. Some disadvantages or limitations of convenience sampling are the biases that the participants may have while taking the survey. Also, since the survey was not chosen at random, it could possibly be likely that the sample could be unrepresentative of the population and you may not be able to generalize the findings.
So, according to the data collected, all 18 participants reported experiencing some form of secondary trauma symptoms within the last week. Out of an overall possible score of 85, the average score was 38.83. As far as the 3 subcategories of the STS scale, intrusion, avoidance, and arousal, the average intrusion score was 11.0 out of 25. Intrusion symptoms include pounding heart, reliving trauma, being upset by reminders about work, thinking of work, and having bad dreams. The average avoidance score was 15.94, the highest possible being 35. Avoidance symptoms include feeling emotionally numb, feeling discouraged, having little interest in being around others, being less active, avoiding reminders of work, avoiding working, and having memory gaps. Lastly, the average arousal score was 11.89, the highest score being 25. Arousal symptoms include trouble sleeping, feeling jumpy, trouble concentrating, being easily annoyed, and expecting bad things to happen.
The secondary traumatic stress scale is a helpful tool in identifying whether individuals have experienced secondary trauma through direct exposure with clients. After compiling the data, it would appear that social workers who work directly with clients and have daily exposure to secondary trauma possess that suggests they have developed secondary traumatic stress. We can also make the assumption that social workers are at risk to develop more significant side effects and long-term effects of STS such as burnout and PTSD. There are obviously limitations to the research study that we conducted, which we will cover in the final paper. Secondary trauma is detrimental to social workers, those served, and agencies involved. This is because secondary trauma can cause psychological distress or dysfunction, cognitive shifts, and relational disturbances. Avoidant, compulsive, and addictive behaviors also co-occur. Social workers experiencing secondary trauma also question the meaning of their work and internalize their clients' experiences, which leads to practitioners leaving the field of social work altogether. In order to prevent and treat secondary trauma, coping and preventative measures must be implemented on the micro, meso, and macro levels.